right, well, should we get started?
Yes, absolutely.
Okay, so I'm Dr. Brittany Panico. I'm a rheumatologist in Phoenix, Arizona. And those of you that are my followers, welcome. If you're part of Dr. Ashai's group, welcome. We're really happy to have everyone. And I'll just let her introduce herself because I think we kind of give our own best introduction. So take it away.
Yeah, absolutely. Thank you for having me, Dr. Panico. I'm Lola Shai. I'm a family physician and owner of In Touch Primary Care. We're a membership-based practice out here in Sugar Land, Texas. And so I'm a primary physician, so I take care of a variety of conditions, so diabetes, high cholesterol, asthma, and of course, osteoporosis. And with our membership approach, at In Touch Primary Care, I help my patients not only achieve, but also consistently maintain a healthy lifestyle so they can live fully and actually enjoy what they have.
That's awesome. Awesome. Yeah. So, can you just kind of give people a little bit of like what direct care means for those of us that may not know?
Yeah, absolutely. So direct primary care or direct care is a model of care where patients have direct access to the doctor. So by cutting out insurance in the model, we're able to have patients reach us directly, and we can spend more time with them. So it's a wonderful model of care for many people because it's not dependent on insurance at all.
Yeah, perfect, perfect. Yeah, I think there's more direct care groups kind of surfacing in the Phoenix area, and like I had kind of mentioned, I think it's a really awesome way to just get that connection with your patient, with your physician, and as specialists, it's a little bit trickier of a model because especially as a rheumatologist, so much of our medications rely on insurance, but we don't have to delve into all of that. But I'm really excited to have your input because you do get to have a little bit more time with people and really get into the nitty gritty of, let's take care of these issues. So I'm excited. So today we've decided to talk about bone health and specifically osteopenia and osteoporosis. So as a rheumatologist, I tend to get involved after the primary care doctor has already evaluated the patient. And we'll kind of, share our stories of how we each interact in that way and take care of this common condition that we're really facing a major healthcare gap, really a gap in treatment across the nation of how we address and take care of bone health. And so it really starts in a preventative way, but if we inherit a patient who is 65 or older, and we'll get into kind of why that age is so important, but what happens if we meet somebody after the fact, after they've already gone through the changes that lead to bone thinning? So without further ado, do you want to define osteopenia and osteoporosis a little bit so that way, from a primary care perspective, we already have a good foundation of what that word means?
Right. Yeah, absolutely. So before I define it, just to give people some background, and I think you've talked about it a little bit, that it is a very common condition, actually. About 54 million Americans have osteoporosis or osteopenia. And basically that means that they have low bone mass or a breakdown of the bone tissue or and a breakdown of the bone tissue and fragile bones, which increases their risk for a fracture. And it's much more common in women than in men, and that's because of that sharp decline in estrogen that all of us, go through at some point in our 40s, usually in our 40s or 50s. The main concern, though, with osteoporosis and osteopenia is that fracture, right? And the fracture risk really depends on the population that we're looking at. But for the most part, in the US, 1.5 million people will have fracture every year from bone disease. That's a lot of people. There is a health cost to that. There's also cost of a lot of 20% of those people end up having to go to a nursing home. 40% of those people would not regain that independence after a fracture. And there's a 10 to 20% increased risk of death after a fracture too. So it's a lot of costs associated with a fracture.
Mm-hmm.
That's why prevention is so exciting because it's a big deal, right? So going to the definition, osteopenia and osteoporosis are diagnosed by a bone density scan. And the bone density scan is an X-ray, and it pretty much compares the bone density of a patient to the bone density of an average 30-year-old healthy person. And if that bone density is 25% lower than the average 30-year-old person, then we say they have osteoporosis. And then if it is 10 to 25% lower than an average 30-year-old healthy person, then we say they have osteopenia. So we use the medical term, T-scores and all that, but the bottom line is we're comparing your bone density to a healthy bone density, and we're saying if it's a lot less, then say you would categorize it as either osteoporosis or osteopenia.
Mm-hmm. Great. And I think too, it's really important to define that with the patient, because when we see this report of numbers, right, we get this report back, and sometimes our patients see the results before we get a chance to review it with them. And when we think about, okay, what is, leading towards, are we leading towards something that's more serious? And osteopenia is that precursor to osteoporosis, which is more severe. And then there's degrees of severity, which we'll touch on as well. And also acknowledging the fall risk of the patient too. I think that's something that, as both a specialist and primary care, watching our patients when they walk through the door, watching them as they transition through our office, and seeing what their balance is like, asking the questions about fall risk. Do you feel safe at home? Do you have rugs on the floor, stairs that you might trip on? And then, have you had a previous fall? Are you falling frequently, or balance issues? And one thing that I don't really get into as much, but I'm really starting to notice, is the dementia factor. So how kind of active are the patients, right? As we think about our older patients, or maybe you're a child of an elderly, taking care of an elderly parent, you're an adult of an elderly parent, and just noticing that, if the patient or your parent is a little bit confused or has dementia, that up and down, night and day sort of misbalance, like how at risk of a fall are they? So all those things are really factors that, when we're speeding through a visit, it's harder to catch. But when we have time, like your model, or when we're going through those questions with people, we can find some of those risks before there's a fracture, right? Before there's an issue. And that's what I like to touch on too, is the prevention, right? This is something that we should be able to catch, hopefully, before it happens, and then treat if it does happen. So that's a wonderful explanation that you gave us. And as a primary care doctor, when should we start talking about bone health to our patients? When as patients, when should we start thinking about bone health?
Right. So, the thing is, actually, from the very beginning of life, we can start thinking about it with our children, because healthy nutrition is a huge part of bone health. So even from infancy, we can start eating healthy, make sure our children are getting adequate calcium and vitamin D, which will help them to build up their peak bone mass, which we'll talk about in a moment. But really, in childhood, and especially in adolescence, we can really start helping our children eat healthy, exercise, avoid smoking, avoid alcohol, and that will help them reach a higher peak bone mass. And then another time that it's important to talk about it will be when women are transitioning into menopause, because that is a very important time period where there's an increased rate of bone loss. So at that point is another opportunity to really encourage people to eat healthy, get an adequate vitamin D and calcium, and to prevent too much bone loss. And then there are other risk factors that can occur with that can increase people's risks of osteopenia and osteoporosis. So like smoking, chronic steroid use, people that have low body weight, people that have autoimmune conditions like rheumatoid arthritis. So there are a lot of opportunities that we can talk about bone health, but really should be a conversation all through one's health.
Yes, exactly. I feel the same way. And also, I think a lot of something that we can incorporate too is talking about vitamin D and calcium intake. So as we're, no longer drinking as much milk, or maybe we become lactose intolerant or sensitive to lactose in our diet, we sort of forget about, calcium intake. And it is really still important to mention, talk about calcium supplementation and vitamin D. I've practiced both in Chicago and here in Arizona, and vitamin D is probably my most #1 prescribed product. And the reason is because in all areas of the country, we are not out in the sun and we wear sunscreen. And so we're, shielding ourselves from the sun, naturally so, right? It can lead to skin cancer, but then also we're protecting ourselves with a barrier that doesn't allow the chemical change to happen from the sun exposure to convert to vitamin D naturally. So checking for vitamin D levels, especially in that peak bone age that you mentioned, will set us up for success as our bones do age and through menopause and even after. And one of the things that we keep track of as we're prescribing medication or have our patients on medications for osteoporosis is we do have to monitor vitamin D. And that's essential because it's a building block for the medication to be effective. So calcium and vitamin D together help us utilize the benefits of the medication. So without it, we're not really setting you up for success. So I love that you talk about nutrition and, how to incorporate all those things, and, mentioned exercise and things like that too. And we can, delve into that a little bit more as well. But those are all super great topics to discuss. And once you have that initial conversation, the first time it might take a little bit longer, it might take a few minutes, but then just those reminders at every follow-up visit, how are you exercising? Are you using weights at all? Are you, taking calcium, stuff like that. So that's awesome. At what point do we need to start thinking about bone density screening? You already mentioned what a DEXA is, or what a bone density screen is, but let's talk about when we need to be checking them.
So recommendations vary about exactly when, but there's a consensus that says, people, women 65 and over, should be screened for osteoporosis with a bone density scan. Now, younger women might need screening if they have risk factors as well. So that is why it's so important not to assume that because you're not 65, you don't need to be screened. So even something as simple as early menopause, which women don't even think about, can be a risk factor for early screening. Mm-hmm. So it's important that we screen starting minimum age 65, but there are many other reasons to do it earlier. And then we would screen, there's typically not a reason to do it more than every 2 years, but sometimes it just depends on the person and their risk factors as well. And then the National Osteoporosis Foundation also recommends screening men 70 and older, or men that have increased risk, have risk factors for osteopenia, osteoporosis. So even men can be affected, and so it's important to keep an eye out for that, especially if they have risk factors.
Absolutely, yes. That is a big part of the population that it's easy to kind of forget about, because a lot of the marketing is based on female bone health. A lot of our discussions are based on menopause and the changes that come after estrogen, and it still is really important to take men into account as well. And it's not so much, I think there's kind of a conception out there that body weight has something to do with it. So we do consider low body mass a risk factor for earlier development of osteopenia and osteoporosis, but equally in overweight and obese patients, they can have it also. And so we can't necessarily rely on the way a person physically looks on the outside, even if they look like they have, a larger bone structure than someone who's petite or thin, they still can have thinning bones essentially. So we really should take into account those age recommendations and risk factors. And that's where, getting to know our patients, getting to know their story is so important, because also, if you have a family history, if your mother went through menopause early or a sister, then you might also be at risk. And so, just talking about those things during our visits is really powerful, so that we know what to sort of be thinking about in future appointments and down the line. So I really like that you included those facts about men as well. And then, we kind of talked about some early treatments, a little bit of prevention with like diet and nutrition and things like that. But let's say you get DEXA back and it shows that a patient is sort of in that osteopenia, early osteoporosis, T-score range or high fracture risk. What's that conversation going to be like for you with them?
Yeah, so at that point, we will talk about risk benefit of starting treatment with medication, because medications are not only for treatment, they can actually prevent, osteoporosis as well. So that will be dependent on the severity, and there are other risk factors. We would want to talk about that. We want to talk about making sure they're getting adequate calcium and vitamin D, check those levels, make sure that making sure they're getting enough of both. And then exercise, weight-bearing exercises will be excellent at that point. This is the time to incorporate those types of things, because now you've gotten a warning that, you have an opportunity to start to reverse some of these things. So, and then, fall risk comes into play as well, and avoiding substances that can increase the risk of a fracture. So like alcohol, and if they are a smoker, obviously that would be a great time to quit. Every time is a great time to quit smoking, but this will be a very good time to quit smoking as well.
Mm-hmm. Great. And one of those things too, and it just kind of came to mind as we're having this conversation, a lot of our population is dependent or relies on sleeping pills. And as a primary care doctor, that's something that, we can kind of alert our patients about too, is, that if it's needed, by all means, that's, they're there for a reason. But if you're somebody who sleepwalks or, is again, increased risk of falling because of medication or more than one type of medication that can increase your risk of falls, it's also a good time just to revisit that discussion of, we're trying everything that we can to protect your bones, but then we also have to address these other things about maybe medication reactions or medication risks. So I just kind of thought of that off the cusp, and I think as we have these conversations, just revisiting the need for medications at each visit. Yeah. So. At what time would you consider referring to a specialist for osteoporosis?
Typically, if a patient has severe osteoporosis, so now where they're at 30% lower bone density compared to the average compared to the normal, so that would be considered severe. Or if they've had multiple fractures, regardless of what their bone mass is, I would want to refer at that point. Another time will be if they couldn't tolerate the medication, the oral medication, and so they need maybe IV or 50 different mode, and we want them to see a specialist at that point. And then if there are reasons they cannot take the medication, so for some people that have had some kind of gastric surgeries or they've had esophageal disorders, then they may not be candidates for oral medications. So at that point, I want to refer. So there are different, many different reasons that come up that we would have to have them see a specialist. And some people, their risk factors are just like if they had a risk factor, they're a high risk for, say, breast cancer, for example, and they're not a good candidate for the medication, for the bisphosphonate, then, that would be another reason that I want to refer.
Yeah, great. And we can kind of talk about a little bit about what those side effects might be like, maybe kind of describe some of the things that we should talk about with bisphosphonates, because that is one of the most common prescriptions that we use. So, when we talk about side effects, what might some of those be like?
Yeah, I think the most common one is just the irritation of the esophagus and the stomach. So some people just can't tolerate it because it's irritating, and or it actually causes irritation. So that's why we say sit up 30 minutes after and all that, drink with lots of water. But the other thing that people should be aware of is their dental health, because that's a big, while they're taking bisphosphonates, they want to make sure that their dental health is good. So that's another thing that is important. But other things like low calcium can occur, not as common, and some other more rare things that I don't think we need to go. There's always a long list of potential side effects, but most people tolerate it very well. So,
yeah. And we can, kind of just briefly talk about some of the other things. So once you do get to the point of being referred to a specialist, so as a rheumatologist, we share sort of the treatment of osteoporosis, depending, I think a lot of it is regionally dependent. So a rheumatologist can be a specialist that sees you, an endocrinologist. There are some people who work within orthopedics or might be more affiliated with an orthopedic group that do primarily bone health. So there's lots of different avenues to get you to a specialist to treat. And it's really helpful to kind of know in your area sort of who those people might be. But as a rheumatologist, I will often see patients, like you said, with more severe osteoporosis. And then we talk about the treatments that are either injections, so injectables that you can either do in the office or as part of an infusion center can offer them as well. There are infusion medications that are in the bisphosphonate family. And then there are anabolic medications that are injectables that are appropriate for some patients as well. And so, without getting into the nitty gritty of all of those things, that would be the next step, as you mentioned, after a bisphosphonate therapy, or if you're not able to tolerate. One thing you mentioned is dental hygiene and dental health, and that is very important as we consider what kind of medications to be on. And there are some recommendations from the Society of Oral and Maxillofacial Surgery that talk about helping to prevent dental complications when you're on osteoporosis medication. So most dentists are aware of that and how to, help you with your bone health, with your teeth and dental health while you're going through the treatment. But that is a great thing to bring up to your dentist as well if you're on medication, to make sure that they're aware of that. That's very important. So another question that I have is, let's say we, try our best to prevent a fracture, but inevitably we have patients that do break a hip or have a compression fracture in their spine. And so at that point, kind of, what is your approach to somebody who you're maybe meeting after the fact?
Right, and unfortunately that does happen, and at that point it would be reviewing what they're doing. So again, making sure that they are, if they have a history, we know that they have a history, they have a potential to have more fractures. So there will be people that will benefit from starting medications. There will be a conversation about risk benefit and more benefit of starting a medication at that point, and then. Also, fall prevention will be huge in that population. So we will be, making sure that they're safe at home and safe walking anywhere we go, walking. And then sometimes physical therapy might be indicated, especially if there are balance issues. So that will be something that we would need to review and assess. And then making sure they're getting that vitamin D and calcium and that's adequate. And then they should have a bone density scan if they haven't had one already. And that will just help us monitor, make sure that things are going in the right direction, and make sure that we're doing all that we can at that point. Do they need more than we have already decided to do with medication?
Mm-hmm. Great. And I mean, you really touched on it. After somebody has a fracture, they're at risk for another one. And that's really one of the most important things to discuss is that, yes, this happened and we can help rebuild your bone strength and bone density, and just addressing, the things to help with that. And also really help, emphasize the importance of independence. And the patients who have a fracture are less likely to get back to their pre-fracture independent functional status. And so really, working with family members and caretakers to come up with a plan of not only how to make their living environment safe, but also how to help them rebuild their confidence to, return to being active after a fracture. I think there's a little bit of, fear of, well, if I broke a bone doing this, what's going to happen if I try to get back into that? And, just really helping patients understand, like, yes, you might not be as active. You might have a little bit more pain after having a surgery, but we can get you back to doing things safely. And, even if that means incorporating a walker or a cane in the beginning, really trying to give patients the hope of, let's get you back to being independent so that they don't just sort of settle with the fact of, okay, well, now I have to be sedentary after this fracture. And I think there's a little bit of a difference between a hip fracture and a vertebral fracture too, right? So, really kind of helping our patients through those phases and emphasizing the importance of physical therapy and, the kind of weight bearing exercises that you talked about. One thing that I like to emphasize, or at least sort of plug, I'm in no way affiliated, but Silver Sneakers. So if you're a Medicare patient, you might have access to this program called Silver Sneakers. And it's directly geared towards, helping Medicare patients stay fit and stay strong. And there's a wide gamut of activities that they, do. You can do it online, you can join a program in your community, but it's one way that Medicare really does help to rebuild sort of that activity emphasis of, keeping our body strong, keeping ourselves active. So you don't deal with, as much insurance being in direct care, but, there are other ways to help kind of use those very similar features. I know a lot of our smart TVs and YouTube has things that you can, do for free or very low cost online. And so, even if it's like a hassle, let's say, to get somebody to physical therapy after a fracture, there's so many resources that we can do it in our own homes to really maximize that. So is there anything in particular that you like to recommend to your patients, that they can do at home or sort of outside of the, going to physical therapy?
Yeah, I think walking is great because it's, low impact exercise and most people will feel comfortable doing it. So if going to physical therapy is an issue, just walking and trying to get exercise at least 30 minutes 3 times a week makes a difference. And then also weight bearing exercises like weights can go a long way. So, they can start with, and you don't need actual weights, right? You just need to get something that weighs about 10 to 15 pounds and you're good to go. So you can really do a lot at home.
Yeah, exactly. So we kind of talked a little bit about direct care, about your sort of practice model in the very beginning, but I just want to circle back to that a little bit. Is there anything in particular you'd like to, say to our viewers today just about how your practice or primary care in general is really set up to help our patients, talk about bone health, talk about screening for osteoporosis, and set the stage of, this is something just like getting a mammogram. This is something that we have to talk about. So what are some unique perks that you have to offer for your patients?
Yes, absolutely. I love talking about direct primary care. So our practice is in Sugar Land, and with the membership approach, it's people are so stressed out usually when they're trying to make an appointment to see the doctor, and a lot of things are done in retrospect. So they have something and then they want to see the doctor. But with our approach, because it's easy to get in to see the doctor and it's so flexible, people can relax during their visits. Our visits are not rushed, and we have that time and that flexibility to really spend with them. So our approach is much more proactive. So we can understand their risks, and then we can, in a stepwise fashion, kind of go through all of it and make sure that we're trying to prevent health conditions. So, for example, in my practice, when I see a new patient, I have like a preventative form that I go through based on their history and all of that. And that helps me assess their risks. And then with that form, over time, I'm looking at, okay, what's the major thing? What's the one thing they can do right now that will make the most difference in their health? And then I work on that, and then I keep going down the list until I feel like we've done everything we can, to decrease their risks for serious health conditions. And then after that, it's now maintaining that. And that's like every time they come in, depending on, the risks, we will have that discussion. But at least once a year, we're going through that whole thing again and making sure that, we're still eating the way we had talked about. We're still exercising the way we talked about. And it makes a big difference because now we can maintain and we can prevent and maintain, a healthy lifestyle. So the direct care model really allows us to do that. And it's very, very difficult to do in the traditional care model.
Yes, it is. And I think a lot of times people, they become a member of a direct model and then kind of wonder, okay, well, what happens if I need a specialist? And there are patients who still maintain some insurance that they can then see specialists for and have their, membership with their primary care. So it is possible to still do both as a patient. You just have to sort of, decide how to manage that within your own, financial goals and things like that, and healthcare needs too, right? So if you're somebody who has, a long-term condition that requires a specialist to treat. The other thing too with medications and the price of medications is that there are ways to get medications covered very effectively through direct models. But then sometimes if you are on a specialty medication, some of our more advanced osteoporosis treatments, you might still benefit from having some insurance coverage. So it's really a great opportunity to, meet with a direct care provider, physician, and talk about, okay, well, as I'm really wanting to prevent things, kind of how will this incorporate with my needs if I have an existing condition? So some people get a little bit nervous of like, okay, I've really committed. I love my direct care, primary care, but then I need a specialist, kind of then what? And there are specialists that are branching out and doing direct models as well. So it doesn't ever hurt to ask for, a different sort of, payment plan with your physician or physician group. So even if you see somebody in an employed practice, it's still possible to get a lot of the benefits just in a different way.
Yeah, and let me add that. Actually, I'll say 70% of my patients have insurance. So I actually encourage them to have insurance, and they can do different types of insurances because for that reason, right? If they need to see a specialist, if they need to go to the emergency room, there is a place for insurance there. But in primary care, it just seems to get in the way. So a lot of the services we offer are not covered by insurance anyway. Like
Mhm.
talking directly to your doctor over the phone, that's not an insurance covered benefit. so,
Right. Yeah, so
um,
you're exactly
so
right.
right. So there are a lot of things that we're doing, and we're doing it this way so that we can prevent things and we can actually spend time with our patients. But having insurance is certainly beneficial, and they can definitely use it outside of practice.
Great, great. Well, how can we find you? How can we find your practice?
Our website is intouchprimarycare.com. So www.intouch.com. And then I can be found on Instagram at intouchprimary or on Facebook at Lola Shai, Ashaye.
Well, thank you so much, Dr. Shai. And I'm AZ Room Doc on Instagram and Dr. Brittany Panico on Facebook. You can find me there. And I'm really so happy that, so many people joined us today. And I hope this just really, these lives are nice because we can post them and play them back. And just hope that, even if you're in your 30s, 40s, even if you're 20, you can still think about bone health. There's never a time that's too soon to think about maintaining and building the strength of your bones, because as we age, our bones change. That's totally natural. We want to preserve the health of our bones to prevent fractures and maintain our independence and longevity and activity. So I'm so thrilled that you joined me today. I really appreciate our conversation and your time. You're a couple hours ahead of me, so I appreciate it. And, hopefully we can get together again and chat about another healthcare topic. So thank you.
Thank you for having me. I really enjoyed it.
All right. Have a great weekend.
Thank you.